Our attempt here is to completely replace the immune system, which we know is broken. We don't know what's wrong with it. It may have something wrong that's different in every single patient. And without knowing that whatever's wrong may change even in the individual, rather than look for the cause, which may be a needle in the haystack as it's proven to be over these last decades, we have the technology today to completely replace the immune system. So to do so, you have to remove the old, and that's what the conditioning regimen does. This is the toxic part of this procedure. And as a result of being capable of completely removing the immune system, you need to have a source of a new one. And that's where the hematopoietic stem cells come in. So just putting in hematopoietic stem cells is probably going to do very little. But if you remove the old system and put in a new one, presumably the new system will not have the same mistake as the old one and no longer attack the central nervous system. And that's in fact what we found. The new system does not have that error anymore as far as we follow the patients. So it turns out that stem cell transplantation and conditioning and the whole field of bone marrow transplantation is a little bit of a similar to cooks and their special recipes. You can have the same recipe, but everybody likes to tweak it their own way. And it turns out that a lot of people use different types of drugs and treatments for the process of conditioning. But that is the key, because if you don't remove fully the old system and it's broken and it continues to attack the central nervous system, it's only a matter of time before the disease comes back, and everyone else has had that problem. They've not fully removed the old system, and therefore maybe they bought a few years with the heavy-duty chemotherapy, but in all cases those studies and those treatments fail to fully contain the disease. And what we've seen with our conditioning regimen and the stem cell transplantation, as far as we followed the patients, nobody's developed any new signs of inflammatory disease. It's a wonderful question, because one always has to try to offset the risks from a treatment, which, let's face it, is a horrendous treatment. We cannot, using our conditioning drugs, target only the immune system. We recognize that the immune system contains the cells that are most rapidly dividing and hence going to be most sensitive to the treatments. There are lots of other rapidly dividing cells in the body that unfortunately are going to fall prey to the same types of treatments. People lose their hair and their nails, and their gastrointestinal tract is compromised because there's rapidly dividing cells. There's lots of side effects. What was deemed to be one of the most risky parts of this, which was infection, because you can imagine without suddenly an entire immune system, you've got to be open to infection. We didn't see a lot of it. But there's an intensive regimen of protection that these patients take. So they're on antibiotics, they're on antivirals, they're on antifungals, and they take these medicines for up to a year to try to protect them, allow the new system to take effect in the body. And everything we've seen is that the new system is fully capable, fully competent of being able to protect the body from invasion. And eventually all the drugs get stopped. So the risk of infection never really arose terribly from that. We had a death early on in this whole procedure using these drugs, but you can see that it's not an easy procedure. There's high risks, including the risk of death, which we still have to quote a treatment-related mortality of possibly up to 1%. So the target for a complete removal of the immune system is acknowledging that the many different medications we have today, and we have many more powerful drugs than we had 20 years ago. We actually started this whole project at the turn of the century. So since then even, we've developed many new agents, and there are more coming. We are able to get to the disease much earlier in the course. We can control the disease with drugs that don't have these kinds of risks. But there are a group of patients that arise, even with their first attack, who've been developing silent disease for a lot of years, and then they suddenly present guns a-blazing disease that really we're not able to control with the usual medications. So early, aggressive, in a young patient with minimal other problems, this is the kind of procedure I think that would probably lead to good control and get the results that we've had. We have not put in primary progressive patients, and for the most part, when we've studied primary progressive patients, there really isn't an abundance of this inflammation, which is really the target of this treatment. So there's low levels of inflammation in a very small subset. Most recent studies said maybe up to 15%. So really not a good group to be testing. Those patients also tend to be older. They tend to have other problems. You have to be a strong person. We've even rejected some people who were heavy smokers and had bad lungs and may have been more prone to certain types of infections. I think you have to be in good general health. You have to have early disease that has really been determined to be aggressive and probably uncontrollable with current medications, but not too far advanced, obviously, because the best benefits are seen in the patients who have not really acquired a lot of disability, and that includes many of the, unfortunately, the progressive patients who've probably had disease a long time, and what they're looking for is a reversal of all the accumulated damage they had, and this is not what this procedure does. Because of our healthcare system, and the fact that most of the care of the patients who've gone through this procedure relies on our national healthcare system, it's only open to Canadians with Canadian healthcare, unfortunately. Well, I think our colleagues across the country are well aware of what we've been doing. Ever since this trial, we've probably done the same number or more transplants. And if anyone thinks they have such a patient, they don't hesitate to contact me. We've transplanted patients from coast to coast. The appropriate patients we're able to identify, but obviously we're not doing a lot of them. And the reason is because there's not a lot of people who really appear with this high aggressive type of disease that's not controllable by the usual medicines. But when you do see someone like that, this is an option that clearly is available and works. The problem there, as you know, is that often the places that are offering this are offering it for one reason only, and that is for the money that they're going to make on it. We don't have enough information on the kind of treatment they're doing, but most likely it's a non-myeloablative, meaning they're not removing the old system. And the reason why it isn't is because they can get away with it. It's safer. They don't have to worry about too much of the complications of having removed an entire immune system. So they will give certain doses of chemotherapy, maybe some other drugs, but they're eventually the disease will come back with those procedures. And unfortunately, in many of the cases, we don't even know what they're doing, and they don't share that kind of information for us. So I really detour medical tourism. I know that some patients believe that the procedure should be done nevertheless, and that we shouldn't be just looking at certain forms of disease. But I would like to deter it for the simple reason that nobody is really following these patients in an orderly way and able to get the kind of information that we've been able to obtain in order to show efficacy.